I'm Yuki Katanosaka from Okayama University. First of all, I'd like to thank the organizer for giving me this opportunity to present to you today. Thank you all for listening to our story. Today, I'd like to talk about the cellular and molecular pathomechanisms in muscular dystrophy associated heart failure, as revealed by the fructine-deficient mice. This slide shows the dystrophin glycoprotein complex and its associated proteins at the sarcolemma. DGC links the intracellular cytoskeleton to extracellular basement membrane, thereby providing structural support for the sarcolemma. Within this complex, alpha-DG is heavily glycosylated and binds tightly to laminin. Mutation of dystrophin and the sarcoglycan results in Duchenne, Becker, and limb-girdle muscular dystrophies. Particularly, those with defect in the DGC develop cardiomyopathies. Recently, it has been shown that loss of glycosylation of alpha-DG impedes the link with the extracellular matrix and results in the development of muscular dystrophy and dilated cardiomyopathy, called DG-pathy. This table lists the DG-pathy genes and their function. The fructine gene FKTN encodes a glycosylation enzyme for alpha-DG, and mutation in this gene can lead to Fukuyama-type muscular dystrophy. To elucidate the molecular mechanism of Fukuyama-type muscular dystrophy-associated cardiomyopathy, we analyzed the cardiac phenotype in fructine-deficient mice. We cannot detect FKTN protein in CKO hearts. Light panels show the glycosylation level of alpha-DG and expression of DGC proteins in control and CKO hearts. The glycosylated form of alpha-DG, stained by 2H6 antibody and DGC immunoreactivity, increased in the sarcolemma at 24 weeks after birth in normal mice, suggesting that the physiological contribution of DGC proteins in the heart increased 6 months after birth. FKTN deficiency not only results in a reduction of alpha-DG glycosylation, but also impaired the expression of DGC proteins in sarcolemma at all developmental stages. Cardiac growth morphology was maintained in CKO hearts. However, the cross-sectional area of cardiomyocyte and fibrosis were increased in CKO hearts 24 to 48 weeks after birth. These mice also show the chamber dilation and cardiac dysfunction. These results show a lack of cardiac dysfunction in young adult CKO mice, despite the marked reduction in DGC proteins, suggesting that membrane fragility is not the sole etiology of cardiac dysfunction. This panel shows the localization of calcium regulatory proteins in 10-month-old mice. Well-ordered pattern of immunofluorescence was observed for sodium-calcium exchanger NCX1, lyanogen receptor, and L-type calcium channel in normal hearts, but not in CKO hearts, suggesting a defect in intracellular calcium handling. The myofilaments were extensively disorganized in CKO, and cardiomyocyte from CKO hearts showed reduced contractility and impaired calcium handling during VC coupling. As a result, calcium contents were lower in SR of CKO myocyte than in those of control. Thus, age-related cardiac dysfunction in CKO mice occurred at cardiomyocyte level. As mentioned above, Young adult CKO mice did not exhibit significant cardiac dysfunction under physiological conditions. Consistently, isolated cardiomyocyte from 10 weeks old CKO mice showed normal contractility and calcium handling for EC coupling. Using these 10 weeks old mice, we examined cardiac hypertrophic response. Control mice shows incremental change in heart weight to body weight ratio and cross-sectional area of cardiomyocyte against adrenergic receptor agonist or pressure overload without increased fibrosis. Conversely, CKO heart showed the chamber dilation, fibrosis with severe cardiac dysfunction under stress conditions. Thus, FKTN deficient hearts are vulnerable to hypertrophic stress, and that cardiac FKTN protein is essential for compensatory hypertrophic responses. Next, we analyze the change in intracellular signaling in CKO heart treated with 2 weeks isoproterenol treatment. Isoproterenol increases the phosphorylation of AKT in control hearts but not in CKO, which instead showed increased phosphorylation of CAM kinase 2, suggesting a downregulation of survival and upregulation of apoptotic signaling. Whereas isoproterenol treatment slightly increased phosphorylation of PKD in control hearts. Basal level of PKD phosphorylation in the absence of isoproterenol were already significantly higher in CKO hearts. Similarly, the phosphorylation of HDAC9 in control hearts was increased by isoproterenol treatment, while the basal phosphorylation in CKO hearts was already extremely high. Thus, FKTN elimination enhanced the PKD signaling pathway, provoking HDAC9 nucleoside plasmic shuttling under physiological conditions. Therefore, FKTN elimination accelerates the progression to heart failure under stress conditions. Why is the hypertrophic response impaired in CKO hearts? This slide shows the change in protein expression in control and CKO hearts at different time points after birth. In spite of the absence of abnormalities in myocyte contractility and calcium handling under physiological conditions, the expression of calcium handling protein is altered in CKO hearts at 60 weeks of age. Homeostasis in young adult CKO cardiomyocyte may have been achieved by reduced calcium influx through LTCC and increased efflux by NCX1 or SACA. In addition, we also observed an upregulation of hypertrophic mediator calcineurin and downregulation of its endogenous inhibitor mCHIP1, along with strong induction of the hypertrophic marker AMP in CKO hearts at 60 weeks of age. Thus, at this stage, hypertrophic remodeling mediated by calcium calcineurin signaling is already upregulated under physiological conditions before abnormality in morphology and contractility emerge. Thus, cardiac plasticity, in other words, reserved capacity in response to cardiac stress, was impaired in CKO hearts. To more directly examine the hypertrophic response of CKO myocyte, we analyze the cell growth during culture with or without phenylephrine for 48 hours. In the presence of phenylephrine, control myocytes showed enhanced sarcomere organization and upregulation of NCX1 expression, which is a sign of maturation of intracellular calcium handling. By contrast, CKO myocyte treated with phenylephrine had no sarcomere formation. cell-cell interaction or spontaneous beating. CKO myocytes show no incremental change of cell area. Calcium contents in the SR of control cardiomyocyte increase during culture with phenylephrine, whereas no such increase was observed in CKO myocyte. These observations suggest that FKTN elimination impairs the hypertrophic response of myocyte. Using these cell models, we examined the subcellular localization of MEF2C and HDAC9 in response to hypertrophic stimuli. In control myocyte, MEF2C was translocated into nuclear with hypertrophic stimulations. On the other hand, HDAC9 was translocated from nuclei to intracellular space. However, both proteins do not work in CKO myocyte. This is one of the reasons why CKO myocytes do not show hypertrophic response. MCK-FKTN deficient mice show normal cardiac physiology in young adult age. To examine the direct effect of FKTN elimination in young adult mice, we generated temporarily controlled cardiomyocyte-specific FKTN deficient mice. By the treatment of 10 weeks old CKO mice for 4 days with tamoxifen, the expression of FKTN protein was greatly suppressed in the heart. As mentioned earlier, expression level of DGC proteins are not so high in 10 weeks mice. Tamoxifen-treated heart for 4 days show normal level of alpha-DG glycosylation and DGC expression at sarcolemma, suggesting that the turnover rate of DGC is not so high. If cardiac function is impaired immediately after tamoxifen administration, it is not due to the reduction of alpha-DG glycosylation and DGC protein expression in the sarcolemma. After tamoxifen treatment, CKO hearts show the chamber dilation and severe cardiac dysfunction. Surprisingly, about 50% of CKO mice dead within 1 week after initiating tamoxifen treatment, suggesting an indispensable role for FKTN in the working heart. Cardiomyocyte isolated from tamoxifen-treated CKO hearts had severe impaired contractility and calcium handling with reduced amplitude, slow decay, and delayed time to peak of electrically evoked calcium transient compared with control. In CKO mice, T-tubule structure and myofilament is severely disordered. Thus, FKTN elimination directly leads to structural and functional cardiomyocyte defect. As shown here, T-tubule structure was severely disordered in FKTN deficient myocyte on day 4. Despite of severe structural disorganization of T-tubule, the expression of NCX1 was not altered. In contrast, junctofilin-2 JP2 expression was clearly reduced in CKO hearts, whereas alpha-tubulin expression is significantly increased. Moreover, the distribution of JP2 was altered in CKO hearts. Therefore, we hypothesize that microtubule densification and JP2 redistribution may be associated with the cardiomyocyte contractile defects via T-tubule remodeling in tamoxifen-treated CKO hearts. In control myocyte, alpha-tubulin immunostaining revealed a regulated meshwork with some polymerized microtubule perpendicular to the muscle fibers. The meshwork pattern of microtubule was lost after the treatment with 10 micromolar colchicine, whereas cardiomyocyte contractility was not affected in control myocyte. In tamoxifen-treated CKO myocyte, we observed a densification of microtubule in parallel with the muscle fiber, and shortening was impaired. Notably, colchicine treatment reduced this densification of microtubules and reversed the impaired contractility in tamoxifen-treated CKO myocytes, suggesting the hyperpolarization of microtubule may have been the resistance to contraction. Golgi apparatus, a major site for the nucleation of microtubules. This red signal indicates the Golgi apparatus. CKO myocytes show abnormal fragmentation of the Golgi apparatus. Interestingly, colchicine treatment induced the fragmentation of Golgi, but no effect on myocyte contractility. The activation of PKD with irimakinone also results in Golgi fragmentation, a densification of microtubules, and contractile dysfunction in control myocyte, suggesting that PKD activation and microtubule densification are involved in the impaired contractility of CKO myocyte. Since FKTN protein localized in Golgi apparatus, loss of FKTN may have affected the maintenance of Golgi structure. Finally, we showed the colchicine ameliorated the heart failure phenotype in tamoxifen-treated CKO mice. Chamber dilation, fibrosis, cardiac dysfunction, and survival rate were all improved by colchicine administration. Thus, microtubule densification is one of the main causes for myocyte contractile dysfunction in muscular dystrophy-related cardiomyopathy. Neonatal cardiomyocyte, isolated from CKO mice, shows abnormal distribution of GM130 signal, which is the cis-Golgi marker proteins. To elucidate how FKTN regulates Golgi structure and thus leads to microtubule accumulation, we performed microarray analysis in control and CKO hearts. A heat map displaying expression level of Golgi apparatus-related genes showed excellent consistency of change within groups. Thus, elimination of FKTN impacts the expression profile of Golgi-related genes, especially genes known to be relevant to nucleation and dynamics of Golgi-related microtubule network was declined in CKO hearts. KEGG analysis showed large fluctuation with high significance for Parkinson's, Huntington's, and Alzheimer's disease. Structural and functional alteration of Golgi apparatus is recognized as a constant pathological hallmark of neurodegenerative disease. A pathway related to hypertrophic and dilated cardiomyopathy was also prominent. These results suggest that the pathological mechanism of cardiac dysfunction induced by FKTN elimination partly overlap with that of neurodegenerative disease. In addition, this panel shows that core DG and LAB3A is co-localized in intracellular space, suggesting the decline in post-Golgi secretory trafficking in CKO myocyte. FKTN protein may be critical for the maintenance of Golgi structure and function. In concluding this presentation, I will summarize our major points. FKTN plays a crucial role in the maintenance of cardiac structure and function. In FKTN deficient hearts, the reduced alpha-DG glycosylation and DGC expression may not be the sole reason for cardiac dysfunction. FKTN deficient hearts shows impaired plasticity in response to hemodynamic stress. Acute FKTN elimination causes severe cardiac dysfunction with myocyte contractile dysfunction and disordered Golgi microtubule networks. FKTN is crucial for the maintenance of Golgi structure and function. Colchicine improves myocyte contractility and ameliorated the heart failure phenotype in the mice. This slide lists my collaborators. Thank you for your attention.